With us, Dr. Abhishek Anand sir, and he'll be talking about publishing options for beginners.
So it's mostly Nilesh slides that has been given to me few days back, and I didn't got time to even edit it. So even if you find Nilesh's name written somewhere, don't be surprised, okay? So yesterday night I thought let's put some improvisation on it, and I just put few of my philosophical slides on it. And then we'll have a chat with one of the most avid publishers from Bihar. So how much time I've got? 7 minutes. So ये मेरे को ARC में बोलने के लिए जो slides हैं, these are from ARC में कि भाई publishing क्यों करना चाहिए private में या नहीं है, that was the main ये था. तो भैया publishing में बहुत time जाता है, पैसा खत्म हो जाता है कि practice में करें या पैसा कमाएं या publish करें क्योंकि time it's a time taking procedure. But I think with time, the more time, I mean jitna you spend time, you get more, you can, I mean in the starting days, once for publishing one article you might take 20 days, 30 days, but once the time is, it comes down to hours also. I find that it's just about, and considering the fact that there is an RPM attached with our practice, rupees per minute, how much you are making, and the amount of time, then there is always a clause ki bhai, how to balance it, you know. Should I devote my time to publishing or should I to academia or should I time to it? And everybody loves money. I love money, everybody loves money. But in the end, we are just not here to create wealth, right? There is a part of intellectual, you know, which we require intellectual stimulation that we all are seeking. As a doctor, we are complex beings. As a businessman, you must think of wealth, but then as a doctor, we all want to evolve. And plus, we love science, we need to be updated to science. And we need intellectual stimulation, we need to clinically evolve and update, and we need to contribute to the eye science. And this was the slide that I contributed. एक दिन तो सबको जाना है भाई. And when you go back, and when you are leaving this world, everybody has one last thing, to leave a mark that we were here, that you were there for some point of time in this infinite galaxy. ये light off कर दिया. And there is no better way. And there is no better way to leave your mark as an ophthalmologist that you were here to live your eternal marks by publishing in academia. That you are there, and sometimes somebody will quote and know that an ophthalmologist contributed this. There are multiple ways you can contribute. You can do a preclinical evaluation, clinical trials, and these are now Nilesh slides. Real world experience, case report and case series, thesis, short project, comments, letter to the editors, editorial review article. So Nilesh, I just want to interact with you, you know. Yesterday I was thinking कि साला दूसरे का slide बोले जाएंगे तो कुछ कैसे how to interact, right? I thought why not, you know, bring out what's inside. We can. So if we see your journey, I think there is a part of you which was a student when you were doing your DNB in Lakshmi Lotus Eye Hospital. And then after that, you have been a very busy, avid practitioner. So we can divide you into two timelines, right? And you also got a very good mentorship from Dr. Ashish Sharma, which is, we all need, you know, which all. But now, so we'll see in the first 3 years of your phase and after that. So how did it start?
So it started much beyond, much before.
So in Lotus,
Lotus.
like many of us digest, no, to publish and all. And you are a second generation ophthalmologist. You are clear cut, right? You wanted to go into private practice.
Yeah.
There was no, like for me, I was never clear cut. There was always two options. I can go here, I can this. But for you, you're pretty, goal oriented, right?
Yes.
That you had to go to this. Then might be, it's very. So how did it all start?
So luckily, I was in the editorial board in my MBBS days.
Right.
For the college.
you were writing from MBBS only?
College magazine, but it was not research publication.
Yeah.
And there was one person, Dr. Amar from Manipal.
Yeah.
He went into US, and in his MBBS, he had published around 25 articles, PubMed indexed. So he gave a lecture, and his entire USMLE journey began because of so much of publishing he did. So
Right.
that inspired me. That told me that okay, you can publish in this stage also. Earlier, I used to think that only professor and all can do. And this entire slide is actually what he told at that time, that you start from the bottom. He started with simple case reports, some letter to editors, and then he grew. So when I went into my diploma, this was not there, so there was we were not able to get good cases, there were not good documentation. So what I did was started publishing in that university journal, which is not nobody reads.
Right.
But at least that gave me that I used to go to professor and get it corrected,
Right.
please correct it, please do it properly, do a peer review, everything, give me comments,
Yeah.
how to improve. And when I went to Ashish sir, actually he had
So
he
you
had
did your diploma and then you went to Ashish.
I went to
So
Ashish
you
sir for
already
DNB.
did your diploma
Yeah.
and then you went to Ashish.
So when I went there,
For
Ashish
secondary
sir-
DNB.
Secondary DNB.
Right.
So Ashish sir had a long list, because before me, Dr. Jay was there 3 years before me, and he used to publish a lot. So at that time, sir had a lot of research ideas and data which was not compiled. So
Right.
sir gave me a project that okay, you take this. He thought that he gave me a question, and then I through the night I read and did the research. So he gave me one of that. One project, and then every week he started giving, because every week I kept writing, and once you start writing, then it becomes very easy.
Yeah.
I was living alone. My wife was doing her PG, so I didn't have anything to do in the evening. So from 5 to
So
8
should
or
we,
9.
if you want to publish, should we send our spouse somewhere else? That is what you want to give the message. No,
if you are starting early.
it needs not to be that tough, right?
So now when I am into private practice, the stark difference is that I can't dedicate 5 to 8 every day in that. So what I have done is taken a call. As you told, we have to balance money and that. So Saturday till 12 or 1.
Few more minutes. It's okay if we continue this discussion.
So Saturday is completely off. From 1 o'clock to 8 o'clock is either research, innovation, presentation, whatever I have to make for the entire week, that is there. So that was a tough call. Everybody was telling that you can't, when I told this idea came to me in Lotus only, and whoever I told, you won't be able to do. Once you start earning money, you will feel that you are losing so much of money because you are not doing for half day. But when I took the call, now everybody is tuned. The entire hospital, even the staff switches off at 1 o'clock. I told them that at least you do your work, you clean your place, you update your system. But they also they go into their own research mode. They start doing Facebook and WhatsApp. But at least that's how I am continuing my journey.
So what we can take away is that I think starts with something which is very easy. Don't take tough projects. I don't think, if you can do, you do it. But then if you are really into, if you are touching and getting a feel of it, that I want to publish it, don't start with something which will drive you away from that thing, from that urge that you got. Start with something very small. Start with something, case report, a letter to the editor. You are by just reading an article and you felt that this requires a comment. Just write to it. So start with something small, a baby step, right? Second is that what is most important is that publishing pays. Publishing pays not in monetary form but in other forms. He has invited faculties at many places. And that is due to the point that even he is sitting in ARA, his articles are traversing these digital borders for him. And it pays in the long run, where you, as an academician, he said that, right? Third is to find a proper mentorship, I think, right? A proper mentorship and a guide if you can get, and stick to it, stick to your timelines that a guide gives you. And that is most important. He performed, and that is why Dr. Ashish, I think, developed a lot of confidence in him, and then is. Fourth is what I feel is that most important point, that there is a very, important term that is being used is publish or perish. But sometimes I feel that it carries a baggage. Perish? Am I going to get obliterated? No, 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 it's not like that. If you find, it's just not holds for a person like me who is working in an institute, but as a publisher, if you see this very fact, a private practitioner doesn't need to publish. But if you find most of the articles currently are coming from private practice or not of national government, many articles are coming from them. So he found a time, he allocated a time of Saturday 1 to 8 that I will dedicate this time for something which I like. He likes to publish and he likes to do research, and he allocated a time, even in his busy private practice. So you need to allocate your time, and at that point of time he doesn't do. So I was just talking yesterday, Dr. You all must be knowing Dr. Ravi Ranjan, right? No, Dr. Ranjan Kumar Rai sir. So he likes to trek these days. And I was just talking that he was planning for a 12 days trek to some place. Then I said that you must be taking a 14-day off. He said, no, I'm taking 1 month off. So he has allocated a fixed time for something which he likes. And that is that he compiles his whole, whatever time he has taken out and puts it in 1 month. So if you want to publish, you can't just do it randomly, I think. You need to take a time in your busy time and then you say that this hours I am going to dedicate and claw to it. I don't think you should take 5 to 10 articles at a time. Go slowly build up. आज इसका इतना खत्म हुआ, आज इसका इंट्रोडक्शन खत्म हुआ, आज इसका मटेरियल मेथड खत्म हुआ, नेक्स्ट वीक्स पे करते करते उसको फाइनल पे ले जाइए. जब फाइनल पे पहुंचने लगे तब नेक्स्ट आर्टिकल पे पकड़िए कि भाई अब नेक्स्ट क्या करना है प्रोजेक्ट. एक ही साथ 10 आर्टिकल करके पूरा कंफ्यूज नहीं हो जाना है. So I will just end my talk here. I am just taking too much time, I think.
Thank you so much, sir. And this publish or perish has now changed to publish and flourish.
Yeah.
So you won't perish, but you will flourish if you start publishing. And one small thing, sir, I want, because in private practice, like most of us are in private practice, this research data collection takes a lot of time, and that is the main hindrance. So what I have done is I have trained one of my OPD attendant only. So if I get a good case, there is already pre-formed formats, and if it is not into an ongoing research, then they make a note of it in a Google sheet. So that Google sheet, any day, whenever I have time, I can access that. I don't have to sit in OPD from my own laptop. I can access, and that's how you keep getting the data.
Basically, what you are pointing is that you form an SOP.
SOP, yeah. SOP for research is.
If you want a person who is a paramedical to run it.
Thank you.
Definitely, we can have another presentation like how to do research work in private practice, because I am really, I am very much interested in research. I did it at SNC. हाँ मैं छोड़ ही इसलिए नहीं रही थी क्योंकि मेरे को रिसर्च करना था. एंड ऑनेस्टली एट प्राइवेट प्रैक्टिस आई एम फेसिंग सो मच ऑफ ट्रबल बिकॉज आई कैन नॉट take Saturdays off because there are only 2 doctors. Other than that, I want to take Thursdays off because that's the low OPD days, but then I do not get the flow. Once it breaks, I do not get the flow, and for writing you need that flow in an environment and everything. So I am actually struggling at private practice with my publications and research work. So I'll definitely talk to you, sir, about that in detail. And the next presenter, I think she is attending the ISOC session. So we'll move on to Dr. Vidhata, and he'll be talking about financial implications of medical legal issues and professional identity insurance. Dr. Vidhata, you are next.
First of all, thank you, Nilesh, for making me OC member. It's been just 3-4 days I became a OC member, and thank you for this opportunity. I was not even prepared for it. So, financial implications of medico-legal issues and professional indemnity insurance. So, why we all ophthalmologists are burdened? It's because of the high-cost technology and in ophthalmology. Yesterday I was seeing one of his presentation on JICE. So it's a 80 lakh rupees machine, and how to get most out of it, he was saying. So it's not, all cannot buy the machine, but we all want to do lot of surgeries and gain as much as we want to. But so the other thing is increasingly competitive environment and social demands, pressure to progressively lower cost to the consumer, and to keep costs down. There is a tendency to do as many as surgery as possible. Not as surgery, but even the OPD we want to increase, like yesterday you were saying. So these things, the pressure leads to the mishaps, and where we lie, this is the reason why we get troubled. And let's see some of the cases that ophthalmologists have faced in past. So case one is on cataract. So this case took place in Madurai 2018, and the case was in Madras High Court. 66 cataract surgeries were done at Joseph Eye Hospital. 61 eyes lost vision, and 5 had partially lost the vision. The compensation awarded was by the Session Court against the Tamil Nadu was reduced from 92 million rupees to 22.5 million rupees for victims of negligence in eye camp, which was partially funded by District Blindness Control Society. And the court made the remarks that there was no approval to run the hospital, consent to operate was not taken from the State Pollution Control Board, no proper design and maintenance of the operating room. There was no anesthetist, no pharmacist, and no facility to do a pre-operative workup. So there was no formalin which was indented to, despite it being out of stock. The second case is from Khurja in UP in 1989, and the case was in Supreme Court of India. 88 eyes had cataract surgery at Lions Club, and all eyes developed endophthalmitis. So the compensation was, in addition to sum of 5,000 rupees, which was already paid by the interim relief, the state government paid further 12,500 to each of the victims. And the court made remarks made that the staff, the operations in the camp should be performed only by a qualified, experienced ophthalmic surgeon registered with Medical Council of India or any state medical council. The camp should not be used as a training ground for postgraduate students, and operating work should not be entrusted to the postgraduate students. There should be a pathologist to examine urine, blood, sugar, and it is preferable to have a dentist check of teeth for sepsis and physician for general medical checkup. All medicines to be used should be of standard quality, duly verified by the doctor in charge of the camp. Third is from Delhi in 1993 under the National Consumer Disputes Redressal Commission. The case was for post-surgery for teresium. What doctor did mistake was, doctor had not advised patient to how much to use mitomycin C, but committed error by not prescribing medicine was to be used for how many days. So the compensation that was awarded was 50,000 rupees. And the court made remarks that doctor was guilty of only limited medical negligence for not having but put down in writing the doses and duration of medicine in the prescription slip. Also, the contributory negligence was ordered by for the patient, because he was held by the court in his case because he continued to take the medicine on his own without consulting the doctor. The case 4, from retinopathy of prematurity, it was in Chennai, Supreme Court of India and National Court Consumer Forum 2009. This was against the government hospital. Pediatrician failed to inform the parents about the ROP screening, and the child was accidentally detected with stage 5 ROP during vaccination visit. 4.5 months later, the birth weight of the child was 1 kg and 250 grams, and the gestational age was 29 weeks. So the compensation awarded was 1.8 crores, and the compensation that is being awarded was calculated on the basis of restitutio in integrum. The aggrieved person should get that amount of money that will put him in the same position as he would not have had he had not sustained that wrong. So the compensation is calculated based on the past medical expenses, future medical expenses, and compensation for the medical agony and lifelong dependence and care, along with the annual interest and inflation of 6% is also added. So the case 5 from Retina in Hyderabad, the allegation was the reported loss of vision following a 78-year-old who developed endophthalmitis after Avastin injection. The compensation awarded was 5 lakh rupees, but the original ask was 51 lakh rupees in 2015. So what was found was there was huge quantity of Pseudomonas and Klebsiella bacteria present in the drug. So Avastin is a single-use vial without preservative. Gross negligence in administering off-label drug Avastin. Parties 1 and 2 sought to have used the same drug as a single use but not by withdrawing drug into the multiple syringes. The sixth case from pediatric ophthalmology from Ernakulam 2016. 9-year-old child underwent ophthalmic surgery for a squint and suffered cardiac asystole towards end of surgery. There was a successful resuscitation, but patient continued to have the episodes of asystole and bradycardia for which pacemaker was placed in that child. Patient subsequently expired. He got the compensation, and the court made the remarks that the consent obtained from the mother of the child was just routine consent and not really an informed consent. Although the anesthesiologist claimed that retrobulbar block was given by the surgeon, 3 documents with the anesthesia notes had no mention of retrobulbar block. Word glyco was written instead of glycopyrrolate in OT record, and use of confusing abbreviation in medical record is a deficiency of the service. So I will skip here. There was a survey. The question asked was, are you aware of professional indemnity insurance? So 89% were aware of the about the indemnity insurance, and 20% were not aware. And the other question was, do you have a professional indemnity insurance? So the maximum person did not have any indemnity insurance. So these are the companies which provide the indemnity insurance, insurer companies you can say. So maximum people had ICICI Lombard and United India Insurance, no financial interest. And there are 2 parts of this legal system. One is the insurance company, which provide just the compensation money, and they won't help you into these legal battles. And the other is the legal service provider. These companies help in your legal battle, like covering the cost of all the expenses and all. So the maximum had the help from the IMA, then the AMC, and the rest had Medico, AMC, Doc Shield, Medef, and MOS. The ideal amount, which was asked, what should be the ideal amount to get the cover? It's more than maximum people had more than 1 crore of the insurance. So where we are now, the Consumer Protection Act 1986 in its definition had excluded free service from purview of Consumer Protection Act. Honorable Supreme Court in its wisdom decided that doctors providing free service should also be covered within purview of Consumer Protection Act. The decision has never been reviewed, and thereafter implications on free medical and eye camps are being realized belatedly and very slow. But recently, there are an increase in number of cases where exuberant penalty has been imposed and has destroyed careers of many of the ophthalmologists. Time has now come to introspect and to factor cost of litigation and compensation into cost of surgery, so that we not only benefit the patient but also safeguard ourselves and help them fulfill the responsibility towards their own dependents. So in conclusion, what I would like to say is we need a good counseling and a very good explained consent to the patient. There should be a clear instructions on what we prescribe to the patient, and the documentation and record maintenance is very important. And most importantly, we all need a good indemnity cover.
Thank you, Dr. Vedat. I just want to ask, how many of us do have the indemnity? You has it? Everybody here has it? Sir, both of you have it? Yeah.
So,
So most of the companies are giving it as a hybrid policy, right? That they are selling legal assistance along with indemnity.
Yeah.
Indemnity is pretty cheap, right? So what should we go for? Is there any company providing because legal, but they also increase the legal fees according to the cover. How is their legal fees
It is-
increasing according to the
it is-
cover? I don't, because
It is just like ULIP, sir. Like ULIP में बोलते हैं ना कि इंश्योरेंस भी होगा आपका और आपका सेविंग भी हो रहा है, बट you get the worst return on ULIPs. So, similarly is this. So, what YOSI has done is YOSI has now partnered with Policy Bazaar. Policy Bazaar has negotiated for YOSI members and their family, like anybody who's YOSI member and their family members, they want to do 50 lakh cover for 800 rupees a year, 1 crore for 1600. No, not indemnity. It is 24/7, 365 days legal assistance, and all the legal charges are paid. If you want to hire if you have a lawyer that you want to hire, then they will pay for that. If you don't have a lawyer, they will provide a lawyer. So it is not like lawyer charges. If you are going to pay, they will compensate for it. They will pay you that. If you don't have a lawyer, then they will. No. 50 lakh is the indemnity, like the compensation that you are paying. Everything else is apart from that. Yeah.
There's one policy, I mean, this same thing is with MOS also, Maharashtra Ophthalmic Society.
So cover you is doing for MOS and AIOS. So that is cover is for AIOS. So they are doing for 4,000 for 50 lakhs, sir. But what it is happening is AIOS has now stopped with cover you once they saw our Policy Bazaar proposal, and now AIOS also is moving to Policy Bazaar from probably next year. That's what Santosh sir and Manoj sir were telling, that they want to do for MOE with Policy Bazaar. But since we as young ophthalmologists are less liable to have that kind of high compensation, so probably AIOS charges will be little higher. YOSI members are getting little cheaper than that.
Now even the states with the
Yeah.
societies are having a collaboration. Even at DOS and Delhi Ophthalmological Society, there are discussions going on with the Cover You, and there are 2 other companies with them, and they are going to buy a bulk purchase, which will give a low cost EMI to all their society members. So I think that's a great initiative by the societies. But I think the major discussions that we were having in the executive meeting is they are not covering up for refractive surgeries, and they are not covering up for cosmetic procedures like your oculoplasty, Botox, and a lot of other things. So that is a major problem with these policies that is there, and that needs to be looked into very carefully.
important point is that the most niggling patients
Are
The refractive surgery ones.
Yes,
But,
the more
but
majority
for
of the compensations are
refractive
happening.
actually, we talked to Policy Bazaar that why it is not included, and actually it is in government ruling that IRDA का जो guidelines है, in that any cosmetic procedure is not. So if we are telling that this is not a cosmetic procedure like -6, -8 का myopia है, and the patient is actually debilitated, he needs it for correction, not for cosmetic purpose, like 0.5 -1 का या 3 का इस तरह का है, तो उसको नहीं
But it's a
करेंगे.
grey zone. It's a
हाँ,
grey
but
zone
but
when your
it but
documents
हाँ
are saying.
Exactly.
नहीं, but गवर्नमेंट पॉलिसी में अभी भी नहीं लिखा हुआ है कि it is still considered
But I think
as a
there are few
cosmetic
companies
procedure.
which are now covering up for refractive surgery as well. That is what DOS was looking into.
रेट्स की बात कर रहे हैं कि भाई आप इसके लिए इतना ले लो और जिसको रिफ्रैक्टिव का कराना है
They are costing the EMI is higher for those who are going for refractive.
या AIOS के थ्रू अगर वो आएगा तो हो जाएगा.
नहीं, जो AIOS के through cover कर रहा है, cover is not taking up refractive. right now.
AIOS का अगर मेमोरेंडम जाता है IRDA को that you please include refractive
refractive. Yes, they should work
as a
on-
professional
as a society.
society.
Yeah.
who have undergone this laser procedure, and they told me that कि मेरा जो है इंश्योरेंस वाला बोला कि नहीं आपका हो जाएगा, चूँकि आपका पावर ज़्यादा है इसलिए, तो प्लीज़ राइट डाउन कि जो मैं करा रहा हूँ इट्स नॉट फॉर कॉस्मेटिक रीजन, इट्स एक्चुअली नीडेड फॉर माय गुड विजन. तो -6 से ऊपर वाला था. तो दे आर सम कंपनी हु आर एक्चुअली.
But it's a difficult situation for the surgeon कि आप लिख दो और कल को आपको you'll have to testify for it.
I have just written that its power is more than -6 and he is handicapped without glass and he has fallen down sometimes. ये वो करके बोला कि सर प्लीज मैंने कर.
वो सर लिखा हुआ भी है उसके डॉक्यूमेंट्स में भी लिखा रहता है कि -6 के ऊपर का और
Thank you. That was a good discussion on this topic. So next we have Dr. Pranita ma'am, and she's going to talk about an update on management of fungal keratitis. An important topic. I think every ophthalmologist should know how to, diagnose any corneal ulcer and how to treat and what is the current management scheme in cases of infective keratitis. So over to you, ma'am.
फुल स्क्रीन इसको फुल स्क्रीन करोगे वो स्वीप डिस्प्ले यहाँ पे ये ऑप्शन होता है मेरा ये लैपटॉप खोला इसी में डाल दूँगा नहीं वो नहीं करना है रुको मैं बता रही हूँ क्या करना है छोड़ दे भाई रुक जा चलो ये वाला में डालो ये खोलो लैपटॉप Sonali, your PPT is ready. You want to start?
You go ahead, ma'am. You're the senior here. Prasanna sir is also ready if at all there's an issue with.
I think it has got opened up now.
Okay. Prasanna sir.
I think it's working now. Delay. So good morning everyone. At the outset I would like to thank Bihar Ophthalmic Society for having me here and the UC team headed by Dr. Nilesh here in Bihar. So thank you for having me here. So I'll be talking about update on management of fungal keratitis, and I'm sure Sonali has a lot of questions to ask me today as well. So as we know, fungal keratitis comes in all different clinical appearances, and we are all well versed with it. It is very common in our subset of patients, and especially in our tropical, subtropical region. Multiple antifungal drugs are available. The main problem here remains is the poor ocular penetration of these drugs, and in comparison to bacterial infections, we do not have a culture sensitivity available for these patients, which makes the task all the more difficult, and there's no comprehensive treatment protocol for management of fungal keratitis for patients of fungal keratitis. Now, the treatment options include topical and systemic antifungals, targeted therapy, and PAX CXL, and when nothing works, TPK is what is required. There are a lot of options of antifungal drugs that are available, but the most commonly used drugs are amphotericin B, natamycin, ketoconazole, voriconazole. We all need to be well versed with their mechanism of action and in which organism do they work well. While the only drug natamycin that is US FDA approved and currently available in a commercially available formulation, so it makes the task all the more challenging when you have a fungal keratitis. Of late, you have a formulation of voriconazole that has been launched by Sunways that is in the form of, I think, Vorisoft that they have come up with. That has made life a little easy. Now we have a pre-prepared formulation of voriconazole available in the market. Previously, we had to reconstitute the Orozole or the one marketed by Orolab. Natamycin, as we all know, works very well in fusarium, and voriconazole works well for Aspergillus and Candida and has poor response to fusarium. Ampho B works well for Candida. We published this detailed pharmacologic therapy of mycotic keratitis, where a detailed literature review was done for all the drugs, the mechanism of action, and their sensitivity. Now, whenever it comes to fungal keratitis, there are two major studies that we refer to. MUT1, which was an RCT, which compared topical NTM with voriconazole, and it said that NTM or natamycin performs better. And the organism that was predominant in that study was fusarium. That is why probably the results was in favor of natamycin. natamycin. MUD2 was again an RCT done to assess the role of oral voriconazole in addition to anti-MN voriconazole topical, wherein they found that oral voriconazole has no additional benefit in patients of fungal keratitis. So that leads to a dilemma, when to start topical therapy, whether single drug, two drugs, when to give oral drugs, whether to give intrastromal, intracameral, or when to proceed for therapeutic keratoplasty are the major problems, challenges that we face. That is how we came up to a decision that we should go for a study wherein we devise a protocol to manage patients of fungal keratitis. So MUT1 said topical voriconazole doesn't work, and MUT2 said oral voriconazole doesn't work. So what to do? A patient who's not responding to topical natamycin, what do you do? That is what was assessed in this TST protocol, which is the topical systemic and targeted therapy protocol that was published in Cornea a few years back. That is what I'm going to highlight in this talk. Any patient of fungal keratitis that presents was treated with topical natamycin 5%. In case patients had a large ulcer, say more than 5 millimeter or more than 50% depth, oral voriconazole or ketoconazole, that is systemic antifungal, is started at the first go. 7 to 10 days, the response is assessed. If there is poor clinical response, then you add on the second antifungal drug, that is your voriconazole. And then again, you assess for the clinical response for 7 to 10 days, because it is unlike bacterial keratitis where the response is going to come in 2 to 3 days. Fungal takes time to respond. So you need to wait 7 to 10 days in each step. After you have added topical voriconazole, if there's poor response, you can go for intrastromal and intracameral injection or a combination of both. And if there is good response to the same, then you can have repeat injection every 48 to 72 hours, up to 3 injection. At any point of time, if there is impending perforation or severe thinning, you can go for therapeutic keratoplasty directly. So we had a total of 3,000 corneal ulcers that had presented over a 3 years time, of which 223 met our inclusion-exclusion criteria were recruited, and they were subjected to this management protocol. So the success of medical management was 74%, in the intrastromal group was 89%, and the overall success rate was nearly 80% with this protocol. By success, we meant that the patient did not require TPK and resolved with medical treatment. TPK were required in 7% for corneal perforation and 13% for non-healing corneal ulcer. Now this is almost similar, results are similar in review of literature compared to any other study that has been published. So what is the advantage? The early combination of the topical therapy, that is natamycin and voriconazole, and timely intervention with the intrastromal intracameral injection results in less complication and an overall success rate which is good. 20% patients only requiring TPK, that too in a tertiary care center where you receive more of complicated patients, is good enough. And if you have a protocol that can be advocated to general ophthalmologists, so patients who are being managed in, say, in the peripheries, in the districts, and if such a protocol is known to the general ophthalmologist, patient care is definitely going to improve and their outcomes are going to be better. So what do you mean by targeted therapy? Intrastromal and intracameral are the two modes, and they are used in recalcitrant infection and deep ulcers. The drugs that are used are voriconazole and amphotericin B. They need to be constituted to the appropriate concentration. The procedure is fairly simple. It can be done by any general ophthalmologist. You need a tuberculin syringe, a 30 gauge needle, and the injection is given 1 to 1.5 millimeter away from the ulcer margin or your infiltrate. So the injection has to be given in the clear cornea, not in the ulcer. Is something very important, because if you reach onto your ulcer or infected area, you may transmit the infection or cause seedings of the infiltrate in the surrounding clear cornea. So the bevel has to be up. You just ensure that your needle or the bevel has, is completely in the intrastromal junction, and then you inject and you create this hydration. So 6 to 7 injection around the ulcer, creating a barrage. You're creating, just like you do a corneal hydration at the end of cataract surgery, you're creating a hydration barrage all around the ulcer to give a high dose concentration of the drug around this ulcer. So now there are a lot of RCTs that have been done to assess the role of intrastromal and intracameral drugs, intracameral antifungal agents in fungal keratitis. While intracameral have not found to be very beneficial in these patients and results in more intraocular inflammation, intrastromal injections have shown good results and definitely can be tried in patients with recalcitrant infections. The other options in recalcitrant keratitis include caspofungin, a drug which is less explored in our setup. Caspofungin is available as IV formulation for patients that are used by medicine people, but not very often by us as ophthalmologists. But yes, if your patient is a proven case of fungal keratitis, is not responding to natamycin and voriconazole, culture sensitivity obviously is not going to be available. Caspofungin is something that can be tried, and the preparation is pretty simple. You need a 1% formulation. It comes as a 50 milligram injection. Just add 5 ml of sterile water and you can prepare a 1% concentration of caspofungin for these patients. Natasol is another drug that Dr. Namrata ma'am and her group has prepared at RP Center. Currently it is not commercially available, but it is something equivalent to natamycin. It's a water-soluble formulation, so the drug penetration, deeper penetration is expected to be better. And in the studies in the non-inferiority trials to natamycin 5%, Natasol 1% has shown equivalent results. Although we need further studies to, actually prove its efficacy, but it is known. Very important and basic in management of fungal ulcer is corneal debridement. Every time you see a patient, debride the ulcer, do betadine cautery or betadine application. That results in a dramatic improvement. Just don't keep prescribing drugs. Careful, close follow-ups, debridement and betadine cautery is something very important. PAC-CXL are fancy things. I haven't personally tried them. But yes, literature says that corneal cross-linking in cases of infective keratitis has been tried in recalcitrant infections where they have shown good results, but the real-life scenario is not something that I am aware of, so I don't really advocate that. Then is Rose Bengal photodynamic antimicrobial therapy. Again, fancy things. They are being tried in the Western countries, not very much in our setup. And yes, when nothing works, therapeutic keratoplasty is the last option for these patients. So to conclude, fungal keratitis is challenging to manage. Every case is different. Management needs to be tailored to your case. Careful follow-up and close monitoring is something very essential and crucial in these patients. Thank you.
Wonderful presentation, ma'am. I have followed some of your work at RP Center, and we have actually written a paper where we referenced your paper as well about the different variations and different organisms that we find in ulcer patients, both bacterial and fungal, and the increase of resistance that we are finding nowadays. So what is the current resistance and how we are shifting to newer drugs now?
So basically, the basic protocol is whenever you have an ulcer, always start with the lower end of antibiotics. Don't just jump to, if you have a bacterial keratitis, it's bacterial, you don't just jump to vancomycin and your higher end drugs. The basic concept is start with your cefazolin or ceftazidime and concentrated tobramycin should be the first line of drugs, and 80% of the patients do respond to these drugs. Although the literature report says that you have a high antimicrobial resistance, but still 70 to 80% of the bacterial ulcers do respond to these basic first line drugs that are described in textbooks, and there are only 10 to 20% of the patients that will be resistant to your cephalosporin groups that will subsequently require vancomycin or piperacillin, tazobactam. So jumping onto those drugs immediately that you see is not something advisable. And often you get referrals from peripheries where you see that patients of bacterial ulcer, large ulcer, and still are being on moxifloxacin and gatifloxacin. Even that is not good enough. So going on to a simple monotherapy or 4th generation fluoroquinolone is also not going to suffice. Preparation of these drugs of cephalosporin dilution is very simple, can be done in your OPD or hospital setup itself. It's just that the basic concept needs to be understood that you need fortified drugs, and the first generation of fortified drugs, that is ceftazidime and tobramycin, are good enough to treat your majority of your patients.
Thank you, ma'am. That was quite elaborate.
Yeah. First slide. You want to comment on that?
I have one question, ma'am. The role of oral in cases with fungal keratitis with hypopyon, the oral drug has any role? Like oral voriconazole, ma'am told that there is no in MUD2 trial there was no added benefit.
I also have a similar question on the same line, that in your algorithm that you all developed. So on the cases with more than 50% involvement, or you shifted the patients initially to systemic therapy. But for the non-responders, you never gave them an option of systemic therapy. Why?
Non-responders, sir?
In your initial regimen.
So you're saying those patients who have an ulcer less than 5 millimeter and less than 50%, oral therapy is not tried. So
no, I am not asking that. In straight way you started them on oral therapy, right?
For those large ulcers.
Large ulcers.
Yes.
But persons who are not that good responders, you never gave them an option of oral
So
therapy.
basically,
So
oral
why
therapy.
why this dichotomy?
Yes, sir. Basically, oral therapy is indicated in patients where there is deeper infiltrate because the topical drug penetration is poor. So you want to give systemic drugs so that the corneal penetration of the drug is better. So non-response is not because it is because of. If you have a superficial ulcer and it is sensitive to that drug, that antifungal agent, it is bound to respond. If it is not responding, it is not because of the drug, but because of the resistance. So even your oral antifungal ketoconazole or voriconazole, you're already giving them topical voriconazole, right? That is the same group. So if it is not responding to topical voriconazole, it will not respond to systemic voriconazole because it is resistant to that drug.
Exactly was my question, and you explained it really well, ma'am. Okay.
What, this one?
Yes.
So I'm presenting on FRC off. I already got the invite and I'm presenting on that.
Yes. Yes.
Yes. FICO, I gave the cornea exam in 2018. Yeah, the cornea one I gave in 2018. But I think the ICO has now discontinued with the subspecialty exam. And AIOS is now in discussion with the ICO to hold that similar exam. So although they are conducting their FAICOs, but they are in collaboration. They were initially also in discussion with ICO. If anybody had given their ICO subspecialty, they were eligible to give the practical exam of AIOS directly as well. So they are in discussion as of now as well. Thank you. Thank you. Prasanna.
Later on, we'll discuss how to prepare yourself for FICO exams also, especially cornea and refractive exams. So we'll have
to attend that ISOC session I just presented.
So we'll have another discussion one-on-one with that. Next, we have Dr. Prasanna, and he's going to talk about blade running your extra academic lifestyle, passport to scholastic health. नहीं नहीं
Yeah, but okay. So thank you, Nilesh, our OC secretary, as well as Nilesh has always put me in non-academic sessions. I'm very grateful for him for that. So for the next few minutes, my dear friends, I'm just going to take you into a very candid, non-academic, whatever journey that I underwent in the last 7 years or 8 years after I started practice. So I've named it the blade running your extra academic lifestyle or passport to scholastic health. So I'm Dr. Prasanna Venkatesh Ramesh, and so thank you again, boss, for having me here, the BOSCON. And I've divided it into different facets. So for academics, yesterday we had mix, and I'll be presenting some more academics in Hall B. But so this is me. This is me as a personality. If you are following me on Instagram. So I take this principle of why so serious, and I don't have a template to life, or rather I just take it in a freestyle, unorthodox manner. You may find me in any one of the looks, and this was all the 3 looks that I pulled off in the last year, 2023. And these are some of my other candid images, and this was one of my haircuts that I did last year for Diwali. So I feel this one was before the haircut. This one was before the hair straightening, and then this one was after this one. And then this followed after that, where I just cut the side. No, yeah, that's something, I mean, I don't know, good genetics maybe, and of course, these are some of my suits, which I really could be, or I just give it to good genes. And then this is a dance which, again, I started into dance for my daughters because I felt I wanted to connect with my daughters, and I started going for their choreo classes because I was feeling that I'm a nerd in college actually. If some of my undergraduate as well as my postgraduate students, my colleagues, when they see this, they get slightly shocked. So this is some of my dance choreographies that I started learning after, I started spending time with my daughters, because I felt that was one area where I could really bond with them. And this really brought me close with my daughters. So these are some of those things that I'm quite old, in my mid 30s, and of course I do get injured as well, which I'll be sharing it. So this is in 2023 in the Tamil Nadu conference in my state, where you can see again I do handstands and all kind of moves. So yes, coming back to exercises, again you can see here, this is my mentor, Dr. Satyen Parthasarathi sir. So when me, Nilesh, we were all in Coimbatore. So you can see the day starts with my mentor and me exercising. So he calls me at 6 o'clock in the morning and he tells me, come, let's go for exercise. I think me, Nilesh, we were all blessed with good mentors, at least a decade back, no, when we all started our journey in Coimbatore. Nilesh was a resident at that time, I was a fellow. And you can see that these are all some of the investments that I did very early in my life, or rather in my mid-20s, keeping in mind I'm still not old and a vayo. So that somehow got me going, my dear friends. Somehow, the BMI or the weight that was still same for me. I'm lucky that my 10-year back clothes are still fitting on me. It's because of some of the investments that I started very early in life. So this was one of the gym that I was doing in Coimbatore, and I'm doing the same in a very different way now, not as aggressive as how I was doing. So this was the vertical climb, which is one of the most toughest exercises, because you need to have a good upper body strength. And most of the calisthenic exercises is what I was actually doing, where if you see, I don't do more of weight training. I use my own body as, the modality with which you exercise. If you see, I don't weight lift, I just use my own body. And again, my mentor here, you can see, so this was taken in 2017, so he is around 60 now, but he must be around 54, 55. So see the passion that he's sharing. So I mean, those were times when these things you can't really explain, and he made a lot of difference in my life. He is currently the Glaucoma Society of India's president as well. You can see for his age, he's trying to compete with me in the vertical handstand as well. Adventures, again, I'm just trying to give different captions, to captivate your attention, as well as just cover what I've just done in the last 7-8 years. So being adventurous is also sometimes I feel it really, brings you from your routine, from why so serious mentality. And this was my recent suit. Some of you who may not know, I have good fond, I like to design my own suits. So this was one that took me 9 months to design. There is a suit only on the other side. You see there is no suit on this side. And this is the half blue that I designed last year. And of course, our YOSI forums, we have all this kind of ophthalmic wars and whatnot. And this was recently in my TNOA conference. That is me along with my wife there. And this is the World Glaucoma. We had the World Glaucoma Week. We had a cricket awareness campaign where we played cricket for awareness for glaucoma. We had Dr. George as the chief guest, and you can see again the costumes that we made. It was slightly on the eccentric tone because we wanted to captivate the attention. And then spirituality is again, of course, each one may have their own views. I am also quite into yogic or tranquility or whatever you say. I think there needs to be a grounding element at the end of the day, whatever it is that you believe in. And these are some of my paths, and these are some of my, again, photographs that whenever I travel to these places like Nepal or something, right? So I was talking about the massive change that happened in my life. So this is my first daughter. Her name is Pranu. And I bought my Harley Davidson when she was in first standard. But I am 63 kilograms. I am 65 now. And this is my daughter, and I am riding a 306 kg bike, and I used to predominantly ride with her. I think the different phases of life is as important as, when she was in third standard, I had my second daughter. So these things actually change you as a person, and you never know how these changes you as a person. So again, this was another phase. Injury. However fit you are, this was last year on November 24th. I had this major disc prolapse in Bangalore, and I was not able to move both my legs. So every time in the Indigo aircraft, I used to see these people who get shifted in wheelchair. And I never expected that I will be shifted in a wheelchair at a very young age where I was not able to move. I went to the casualty and I had an IV tramadol also. Despite that I was not able to move. It was because of severe pain for a disc prolapse. And I had my FICO exams on December 17th last year. My theory for cataract. I'm also like ma'am, so I get inspired when I see those kind of slides. I finished my FICO glaucoma in 2019, but then I wanted to do my FICO cataract. So I had 21 days to bounce back, but luckily this injury really helped me to study because I had a lot of time to study and I was able to get the FICO gold medal, which happened in the next month, December 17th, and the practicals happened in January. So again, that doesn't stop you. You have to keep going because in life we are all humans. We cannot, pause, or of course pausing is important, but you can't stop. Again, this is another disco suit of mine. Now I just use this prophylactic belt when I do the dance and etc. And compassion. So compassion is another thing. Again, these are things that I really felt which makes you a better person, or certain things I still don't have the right words to explain my emotions or my journey here. So this was one of the 16-year-old Sturge-Weber syndrome baby which presented to me. And again you can see it's almost a complete ophthalmus unilateral. See how bad the cornea is, and you can see the enlargement of the globe. And I operated this baby on 16 days, trabeculectomy with trabeculotomy. And now the baby is 9.5 to 10 months old. And you can see the happiness and joy and see the clear cornea compared to the hazy cornea here. So these are things every time when the child comes to my OPD, I've seen it that, the amount of joy that you get. I've seen seniors posting about this, but see the cornea, and every time when I see this baby, and now it's just going to keep coming and coming. And I mean, these things really, it makes you feel that your life is going a full circle and it is really worthwhile. And of course, I'm an MIGS surgeon. Yesterday I had 2 talks on MIGS, one on suture gap and one on eye stent. And these are some of my other surgical aspirations which I really invest my time in. There are totally 6 different mixed surgeries. I published all this in my YouTube channel as well as in peer-reviewed indexed PubMed journals as well. For the scientific deliberations, you can feel free to go and see that. It's something that is up and booming. And recently I have started venturing into live surgeries. The kick that you get from live surgeries, it's too good actually. So I think Nilesh did a live surgery very recently, if I'm not wrong, in BR, or I think 3 months back, right? You too had a live surgery in cataract. So the live surgeries give you a different different perspective. The ball game is like playing an IPL game or an IPL final, something like that. It really tests you. Again, mentorship magic. Now I've started to train a lot of young ophthalmologists. This was one of my first fellows from Salem. This is from Kerala. And so I'm on the other side, or I'm trying to be on the other side. And this is exploring the world. So I like to explore the world. And this is Melbourne is where I learned my MIGS in a wet lab. And Italy is where I refined myself, where in between there was a lockdown. And I feel as a whole, these are some of my academic achievements. Of course, my rejections are in the 60s. This is just Indian Journal of Ophthalmology, my previous dashboard, where my acceptance is 53, but my rejections are higher. And similarly, in the new dashboard also, if you see, the rejections is around 13 and the published is around 23. I have 67 publications in IJO alone. Now it's 69 as we speak. I also believe in extensive publishing. Being a private practitioner, I give a lot of time and weightage. And I utilized my COVID time, first lockdown. I took out all my data for the first 3 months. I think the whole world was locked down. That really served as a benefit in disguise, or for me to start my journey. And these are some of my citations. This has touched 100 yesterday. So I also take pride in citations as well. It's a very baby one compared to the doyences who have entered the 2% list. But for the last 3 years, I have had 100 citations every consecutive years in the last 3 years. And citations helps you understand that what is the paper that you are being associated for by your peers. And I also believe in having your Web of Science, ResearchGate, YouTube, even ORCID as well, if you can. And these are some of my achievements in the recent conferences where people have recognized me for my publication work, or be it the innovations that I do. And I was also lucky to win the IJO Certificate of Merit in 2022 and the Silver Award in 2023. And I do a lot of international travel, network with lot of people like Clement Tam, Aik Ahmed. I think these personalities are very inspiring. Sometimes I feel I am just trying to be the Indian version of them. I don't know. And I think that's the way, my dear friends. Certain things, it's just a journey that we keep going. There is no real, template to life. Don't take it seriously. And I'm also thankful for the YOSI GC. I was not part of the GC last term. Nilesh was. That they honored me with the Best Young Ophthalmologist of the Year for 2022 to 2024. And people like Nilesh, when they are in the leadership roles, I think they recognize good talents like me. And today I am filling in his boots in YOSI as well. So I think we are all in a platform to uplift each other. So that's why he has brought in 6 to 7 different topics here. And we are all here trying to, share our knowledge and our expertise, helping each other. And these are some of my other pictures as well, which I always take pride after I finish a conference. And I'm lucky to, done this and met so many stalwarts. And also, I am an imaging person. To summarize my talk, for me, everything is imaging and videos. So I have this habit of taking a lot of photographs. So these are some of my photographs, which are award-winning as well as published in ASCRS, IRSA program books, and I consecutively participate in these events. I always feel creativity comes from imaging as well as videos, and these are some of my videos. For the want of time, I am not going to the depth, but I can always tell you how I shot each image that you see here. So maybe this one particular image, I would want to throw light is, when I was doing this cataract surgery, I had my side ports slightly weaker. When I was doing the surgery, both the iris started to prolapse on either side. The rexis was well centered and I was able to see an eye within an eye. So I just paused my surgery, took a video for 10 seconds and this is one of my best images that I've seen and I've never seen it again. You cannot really create this image. It has to happen on its own. So there are many different images like that. Christmas is round the corner and we have the Christmas tree cataract. We are exploring anterion, edon, and even a simple asteroidilosis can look very eye candy. And this is one of my publications in the academy where it was on the cover image where Axenfeld-Rieger syndrome tube placed in the sulcus, and this was surgery done on a pregnant woman who was 8 months old. And I also publish in other cover images. I've been lucky to have so many cover images. Most of the regional, national and the international journals recognize me for my images. And also in 2022, the image that you would have seen on the program book, when Partha sir was the scientific committee chairman, that was done by me. And of course, now I have my own startup. I have labeled it the Mahatma Center of Moving Images Private Limited. I have my startup where I have started designing a lot of 3D printing, 3D imagery related work. And I always believe in acknowledging my team. We have a group of optometrists and doctors. You can see 2 doctors and 4 optometrists, and we also have a in-house statistician as well. So my team is also my strength, and we have filed 6 patents, and they are patent provisioning, especially for the holograms. That was the first ophthalmic holograms with true confocal fundus images. You can see what he is doing in thin air, right? He is actually visualizing the circle of Willis, the cavernous sinus. So we did have 6 innovations from our startup where animations, unanimations, 3D printing, HoloLens, augmented reality and puzzle making. So we did this, and you can catch all these 6 innovations in this QR codes, or you can connect us at different places where we'll be able to help you. And these are some of my named awards and oration. And last comes the leadership with good leaders like Nilesh and many other scientific people here. I think Pranita ma'am is there and many other seniors from BOS is also there. Good leaders help identify good talents, and currently I'm in the IJO board as well as my state as well. And of course our very fond YOSI, where I'm trying my best to fill in Nilesh's shoes, which he has done very well for the last 2 years. So thank you once again, dear all. And for me now, I'm currently pursuing my APAO LDP program. For all the YOs out here, it's a wonderful opportunity which is presented every year. It's something that you have to know. And I'll end this with this video, with an audio. So this is one of my OPL videos which I made with my own content. This audio will be there, right? Yeah, I'm just playing it for 30 seconds. This is my daughter, second daughter. Second one, first one. So thank you once again. Thank you.
I think it's a shame we do not have a bigger audience to witness what we witnessed right now. It's a pleasure to our eyes, whatever you've achieved at such a young age. And Nilesh sir, you have eyes on him. I think you know got the talent in front of us, and it's a treat to our eyes to witness you today, sir.
Again, to answer first part of your question, my mentor has told me one thing, that the number of audience don't matter. The work that we do will always reach eventually. That is one. And of course, Satyen sir again. So he sent me a flute. I think the person will be playing a flute and one dog will be sitting, listening to the flute. So he used to send me this one for a long time back. So, and that is one. And second thing, I had an issue with my flight yesterday. And not only that, Nilesh is one of the leaders that I am looking up to for a lot of different reasons. I told you, right? He was instrumental in making me be here because from a place like Tiruchi is a tier 2, tier 3 city. There is only one flight which connects Darbhanga to Tiruchi, and the transit period also, no? So he is very instrumental. And
Thank you for coming. And he is like, it is tiring to see his presentation only, how he manages to do everything, because we are seeing just 7 minutes of what he is doing in an entire year, and constantly he is having super energy. So thank you for always taking, because I make him do these slides. He wants to do some academic topics, and I always tell that no, your extra academic facet also needs to come up. So next oration is going to start. So we'll have Dr. Ayushi Sinha.
Next we have Dr. Ayushi, and she'll be talking about role of Nepafenac in pain and inflammation management.
Good morning, everyone. I am Dr. Ayushi Sinha, and I shall be discussing the role of Nepafenac in management of pain and inflammation. So we need to discuss it because cataract is the most important commonly done surgery worldwide, and cataract surgery obviously is the most commonly done surgery, and we as surgeons aim to give the best outcomes in terms of visual acuity, reduce discomfort, reduce pain, reduce recovery time, because the patient expectation is quite a lot with cataract surgery. And controlling inflammation, controlling pain is paramount. It depends patient to patient, but there is a high incidence of pain in the first week after cataract surgery. And studies keep going on the management of it. So we have two options, steroids versus NSAIDs. NSAIDs, as we all know, act on cyclooxygenase, reducing the production of prostaglandins and reducing inflammation. So what it does is decreases intraoperative miosis, reduces post-op pain, photophobia, rise in intraocular pressure, reduction in post-op CME. So the important thing is multiple studies have been done comparing NSAIDs versus steroids or NSAIDs with steroids, and the consensus of all of it is the synergistic effect of NSAID and steroid is effective, and it reduces cells flare also, and reduces other inflammatory complications in the post-op period. So steroid plus NSAID is synergistic, that's what this says. And the other problem is compliance of the patient. So NSAID traditionally was Nepafenac, which was given thrice a day, 0.1%, and adherence to therapy became a factor because patients, although well educated, although well informed, might not be able to adhere to therapy for a long period of time. So at day 7, 27% of patients in the study failed to adhere to the therapy as prescribed. So Nepafenac 0.3% gives this advantage. It's a powerful post-op pain and inflammation control agent. The unique prodrug formulation has a lesser size compared to the nepafenac 0.1%, so increases the bioavailability in the tissue, increases absorption, increases retention time, and gives a once daily dosing. So this is all how you give the drug. So basically you give the drug once, you start once 1 day prior to the surgery and give it once 90 minutes before the surgery, and then continue it for 2 weeks after the surgery. The presence of guar gum, that is HP guar, hydroxypropyl guar in this acts as a suspending, thickening, stabilizing agent, increasing its acceptance for the patient and penetrance. So this is the study that we will discuss in brief. So it's a multi-center randomized double mask phase 3 study done over North America and Europe over 65 centers, where they studied 2120 patients divided in so 4 groups. One received, the 817 patients received nepafenac 0.3%, 819 patients received nepafenac 0.1%, and the control groups were 200 patients receiving 0.3% of vehicle, nepafenac 0.3% vehicle, and 206 patients receiving nepafenac 0.1% vehicle. And all the patients received antibiotics. So the vehicle groups did not have any anti-inflammatory treatment, and what they 6 visits of the patient were done. The primary endpoint was the control of inflammation, that is cells flare, a score of 0 for cells and flare. And secondary efficacy was the pain scoring, which was also done over 5 scores. So the primary endpoint showed that nepafenac 0.3% was statistically significantly better compared to the vehicle group, and it was non-inferior to the 0.1% group. And even in terms of the secondary endpoint, that is the pain resolution, the nepafenac 0.3% was non-inferior to the 0.1% group. So it was well tolerated to the patient, and there were no serious adverse effects. So once daily dosing would be very effective, is very effective, has been proven in the multiple studies that have been done. Also has a higher acceptance in terms of lesser dosing intervals, well tolerated with good safety profile, and this can be used by us. Thank you.
Thank you so much, ma'am. And meanwhile, Dr. Sonali sets up her presentation. I would like to ask Subhash sir. Sir, what is your post-op regime right now? Because there is a growing trend that you reduce steroid, move to nepafenac. Few surgeons have stopped giving a steroid altogether. So, sir, your regimen?
I still give steroid for 6 weeks, but in tapering doses. And since the patient had already bought this nepafenac before surgery, so I asked the patient to just finish that bottle after the surgery. But only in the high-risk cases like uveitic patient or diabetic patient, I tried to give it a little longer, the nepafenac drop. Yeah, I start.
Moving to the last talk of today, Dr. Sonali is going to present on...
After seeing Dr. Prasanna's slide, I think mine is going to be a little dull. But anyways, this is my first EOC presentation. I've been a member for quite a while, but this is my first time. So I'm quite scared to present today this topic because I might be thrown out of DDC after this. So legacy and expectations, the struggles of a second generation eye care professionals. So before this, I did my MS from Safdarjung, New Delhi, and I then went for to pursue my interest, I went for a cornea refractive surgery fellowship to Sadhguru Netri Chikitsalaya. Life was going on well. I was doing a lot of academic work and research work as well. But then when I came to private practice with my father, this is the look I get every day in the morning. Every day he is waiting for me to make some mistake, and he just wants to give me this look, what have you done now? Okay, so you already know Dr. Strange, he's a superhero. Today I'll introduce you to Dr. Strangest. Why I call him Dr. Strangest? Because he has so much expectations from us, he just wants us to be like him. Like he has been the person he is, and he is a perfectionist, we all know that. But he wakes up at 6 o'clock, sharp 7:30, he'll go to the OT, he'll complete the OT by 11:30, 12, and then only he'll have breakfast. When half of the nation is planning for their lunch, he has his breakfast. Then he'll go back to OPD, and at 4:35 he'll has his lunch. When we go for tea, he has his lunch. And he expects everybody to follow that routine. At 7:30 when we are like, okay, chalo, आज का दिन निकल गया, पापा, can we go now? And then again I get the same look. हाँ, तुम्हारा बाप तो काम करते रहेगा, तुम लोग जाओ. So, since childhood, I have just been told like, हम तो नदी पार करके जाते थे पढ़ाई करने, तुम लोग ने क्या किया, तुम्हारे पास तो सब कुछ है, फिर भी तुम लोग अच्छे से नहीं पढ़ते हो. हम लालटेन के नीचे पढ़ते थे. You guys are privileged, you need to do so much, you need to take life seriously, and nothing in this world comes granted, and you need to make your work, you need to struggle yourself to pave a way. ठीक है, तो I used to listen. That time I didn't understand what he was telling. But now also whenever I want to chat with him कि पापा what are your plans for Sunday, this is what I get. चलो तुमने सर्जरी देखा वो वाला जो मैंने भेजा था, देखा तो नहीं होगा, इतना तो बिजी रहते हो तुम लोग, सारा काम तो तुम्हारा बाप करता है. Now I really question myself, out of all the torture that I have got since childhood, why did I still choose medical career? I mean, I have seen him struggle and been stressed because of the patients and working day and night, and still I knew the climax of the picture and I jumped into it. And after 13 years of medical career, all I am getting paid is in pennies, and the irony is my own father is right now paying me in pennies. Okay. So I'll just briefly tell what happens to me on a daily basis at DDEC. So any patient who comes, मुझे डॉक्टर सुभाष को दिखाना है, तो my receptionist बोले वो उनका तो नंबर फुल हो गया. अरे अभी तो 8 ही बजे कैसे नंबर फुल हो गया? तो देर से कि उनका तो 4 बजे से लग रहा था, 6 ही बजे फुल हो गया, आपको दूसरे डॉक्टर से दिखा देते, आइए. तो फिर कहा नहीं हमको सुभाषे सर से दिखाना है, हमको किसी और से नहीं दिखाना है. अरे नहीं आपको तो कॉर्निया का प्रॉब्लम लग रहा है, डॉक्टर सोनाली है वो देख लेंगी, हमको कोई छोटा छोटा डॉक्टर से नहीं दिखाया, हम आए हैं, हम सर ही को दिखा के जाएंगे. Somehow if the patient मान लो gets convinced to show me, he like pranam sister ji. This is something that I've been facing since residency, and till date I cannot be normalized to it. चलो ठीक है, आई इग्नोर द प्रॉब्लम, इट्स एन जनरल थिंग. चलो मैडम सॉरी जी, मेरे आँख में ना मांस चढ़ गया. हम क्या अच्छा आपको तो नखूना लग रहा है, ब्ला ब्ला ब्ला, इसका सर्जरी लगेगा. अच्छा ठीक है सर देखेंगे ना. उनका ठीक है, हाँ ब्ला ब्ला ब्ला, आपको सर्जरी लगेगा, इसका ये रिस्क होता है, वो ठीक है फर्स्ट सर तो देखेंगे ना. So that happens to me on a daily basis, and I'm telling you, it hits your morale sometimes, because when I joined, before that, I think I struggled my way through the training process. I think I knew something and patients would come to me. But here the scenario was very different. Patients were actually coming for your father. They were not coming by your name. So it was a struggle in the initial few days of my private practice, but with the time I learned the hard truth that you can never be the lead role of any picture. He is the main lead role, and that is why there has been 3 sequels of this movie. So he is Kartik Aaryan, and I am this funny Pandit ji who is standing in behind. Maybe someday when people like my performance, I might become Madhuri Dixit, but I will never be able to replace the lead hero of the movie. Okay, so with that, I want to say that the impact of any legacy that happens, the family in medicine that happens to us, it really influences your career choice, and it really affects your likes and dislikes from a very young age, what you want to do, and you need to navigate your way through it. You can never be stuck with that expectations, and you need to navigate your own self-reflection in that and to fill your medical career. It will obviously provide you motivation, but at the same time you'll also be pressurized, and it may give you it may give you support in the beginning, but it will also be giving you a competitive atmosphere. So balancing everything and navigating your own aspirations and your own dislikes and what you want from your life is also important, at the same time running inside a legacy. So before that, you should be honoring your heritage, because it is there since years, because your forefathers and your previous generation had struggled and worked that much, so you can have the privilege of standing at a higher level right now. For that, you cannot just come and sit after doing an MBBS or MS and just sit with your father. You need to have your own comprehensive training and struggle so that nobody has to question you. And for that, residency is not just enough. You need to do a fellowship or an SRship. You need to regularly attend workshops and also short-term training if at all it is required. It's a lifelong commitment. Even at the age of 60, I see him studying and reading, and we are just in our 30s. So we can eagerly, and most importantly, we have to keep ourselves very much focused and updated with the new techniques. So how can you improve your patient outcome and your clinical skill is by having a good clinical sense with the patients. A person who has good surgical hands or good academic, but if you're a good clinician, you will always have patient coming back to you. Time management, which I really think I lack and I need to work on it. Being on time, I think he has been sitting since 8 o'clock behind, today waiting for us, and we came at 8:30. So that's how he has always been before time. He's not on time, he's always been before time. And this is something that we need to learn from him also. And understanding the fact that before a cornea surgeon or a retina surgeon, we have to be a general ophthalmologist and see everything in an integrated manner, and then go specifically into the conclusion or a diagnosis. Building a trust with the patient is very important. Now also, I know initially few days I was really struggling with the private practice, but now because you talk to the patient and I am not just doing a worker I'm not an assistant, I am also a qualified doctor. So I need to talk to the patients, gain their trust and talk to them in their own language and in their own local thing. So many times I now see patients walking, I do the workup, they go from one room to the another. After showing him, they come back to me. So this is what sir has written, it is okay now. So that's the level of trust you have to develop, that patients come back from the other room back to you to clarify what the other doctor has written. So empathy is very important. Also, when you work in an environment, you have another well-qualified doctors with you, you need to have interdisciplinary approach. So depending on each other, I know Dr. Shivani is much more qualified in squint surgeries and pediatric care. So I do refer patients to us. There are so many things I learn from her. She learns a lot of cornea things from me. We learn a lot of cornea, retina things from the two colleagues we have. So interdependency, it also increases the trust amongst ourselves and also the knowledge that we share amongst us. Another thing, how we can increase our approach to the community is by participating health camps, conducting health camps, attending awareness programs, putting up educational videos. Nowadays, I'm sharing a platform with DDC, that is Eyes Wise with Sonali, where I've been putting up videos of clinical diagnostic cases. We've had 2 episodes, and another one we're coming up in the next few weeks. So social media calls a very important role, and platforms like, I think for an ophthalmologist, young ophthalmologist, Yossi is a very good platform. And Nilesh sir, thankfully you've been doing it so well, and we are all inspired by how a young ophthalmologist is doing so great, and it's an inspiration for us also. So another, like I said in the beginning also, you need to find your own identity amongst us. So marketing yourself. So engaging in academic forums. Like currently I can say what I am doing right now is also marketing myself, because I am talking about what I have done and what little I have achieved in life and what are my struggles. So I'm actually telling people about my own thing. This not just gives you new platforms and new roles, but also opens up platforms for collaborative partnerships. Then research and publication, we've had a very detailed discussion how important it is, and it is my personal interest, and that's why I think my brain works in a very different way whenever I see a patient, because I have that research mind with me. And engaging yourself in extracurricular activities, some engagements, like even a marathon can give you a lot of contacts. Networking with people is very important. So this is some of the love and support and blessings that I've got despite the struggles that I've had in 4 months, but I was able to make my own space in a short span. These are some of the blessings of the patient that they come and they give, some of the love the children have shown. These are some of the reviews I got in the last 3 to 4 months at just struggling my way through DDEC as a private practitioner. So in the end, I would say he has been my hero. He has taught me a lot of things, but it is not necessary that I cannot be a hero. And from all the people who have seen me from a child, for him I can be a child, but for other people I want to show that we are now colleagues. We are trained enough and we are thriving and learning new things so that we can make a mark in the society. So thank you so much.
This is so heartening to see actually. Subhash sir must be feeling so proud that he sings.
वो नहीं है, लेटर हेड ने तो इसको डिसमिस कर ही देते एंड योसी सेक्रेटरी शुड पुट समथिंग कि केवल बाप का बुराई नहीं कर rightly said that I am little difficult to handle for
Very difficult.
everyone not here, but even in the IGMS people still recognize me कि वो आता था घड़ी मिलाता था सब लोग. तो इस तरह से मेरा एक reputation बना हुआ that I can't change. that I have inculcated from my RP center time. तो वैसा है, टाइम में आई एम पंक्चुअल, आई विल बी पंक्चुअल, जाना भी होगा ऊपर तो टाइम से ही जाएंगे तो वो तो चीज़ है, लेकिन लिविंग ए साइड आई एम वेरी फॉर्चुनेट दैट आई हैव गॉट माई टैलेंटेड डॉटर एंड सन इन लॉ, और मेरा एक और बेटा भी हो रहा है. एंड only thing that the next generation should never think that they are always under pressure. They have the biggest advantage that they can scale up from here. They have already got a solid background, because nowadays venturing into anything as a solo practitioner or anything alone is not so easy. Gone are the days when just came to Patna, the field was almost barren. So we started and people just looked up to us because we were definitely from a very good institute. We had a solid background of working with dedication at IGMS. So they don't have that. They have got the opportunity, and it's not that you cannot make patient. You can always make your patient. You have to work in a different way, and you can add on some values like, I'm not capable of handling so many things. If you think of just having some better instrument, more advanced gadget that you can work upon. So that is the message I just want to give to others, like always take advantage of your previous say and then scale up from there to a new level, to higher level. What Nilesh is doing from, like in ARA, nobody knows आरा में क्या है लेवल ऑफ, ये नीलेश इज टेकिंग अप टू द नेक्स्ट लेवल. डॉक्टर कन्हैया सिंह को तो हम लोग बहुत पहले जानते हैं, हम लोग तो बहुत रिगार्ड करते हैं, पहले से उनकी प्रैक्टिस इतनी अच्छी, इतने अच्छे सर्जन सब कुछ हैं, लेकिन ये ही इज टेकिंग टू सम अनदर लेवल. तो वो करना है, एंड ऑलवेज कीप दैट इन माइंड दैट यू हैव टू, डार्विन्स थ्योरी है अभी के समय में कि सर्वाइवल फॉर द फिटेस्ट, तो उसके लिए करना है.
Actually, what sir you are telling is very good. Like if I start competing with my father कि वो फेको कर रहे हैं, I will also do a good फेको. It is not going to work. Some value addition needs to be there. That's how it will. That's how patients also started recognizing कि ये वाला काम यही करते हैं. Then slowly 1 to 2, 2 to 3 इस तरह हुआ. Dr. Prasanna is also second generation ophthalmologist.
One more thing, they should not think that in 6 months time they will be as popular as Dr. Subhash.
Yeah.
Patience has to be there. So many people joined me and worked, and they went out and they are doing extremely well. And I always try to promote everyone जो भी हमारे यहाँ काम करते हैं, it is कि ऐसे नहीं होता है, and I am doing slowly, but everyone has to have patience. अभी के बच्चों में थोड़ा patience कम है.
So the look that you told sir gives you in the morning, every morning when I was operating initially, post op देख के पापा का भी वही हाल होता कि ये क्या करके रख दिया है, but slowly over time, like he also told patient, and then he told me that you face the patient. I am not going to take responsibility for the cases you are doing. You have to take responsibility. One question that didn't come in your presentation, and I wanted to ask Dr. Prasanna also, you also, it's not only the patient. The staff of the center also should take you in regard that you are now a consultant and not a child anymore, because they are seeing us from a very small age. They have seen us as children failing in certain exams and getting scolded for everything, and suddenly they have to give you regard as a consultant. So how did you win over your staff, and also Dr. Prasanna for the same?
So eventually everything takes time. They have seen the perfectionist. They are still, I am not a perfectionist right now. They have seen me. But when you work honestly and the patients comes out with a smiling face, they give reviews to 10 people outside. I think that gains the confidence of the staffs also. Then also they bring their own relatives to show you. So many times cornea cases, they do not go anywhere. They come directly to me now. So that's how the patient, it's the word of mouth that really helps.
Yeah, again, slightly doing metaphorically, I think all of us would have seen the film Inception also. The climax of the movie is actually a father and son kind of a thing, where they will not be having that sync with each other. But what I have noticed when you started, the pitfalls of second generation or nepotism, so that itself is a own struggle by its way, because you will always try to fill in your parents' shoes, but it will take some time to understand that no, you cannot do that. You have to be on your own. And winning the respect of the staffs is another thing that you can do only by your practice, guided by our parents. So when I was seeing sirs and your picture, So initially we all will go through that phase where, the father will be looking at you like a kid, and we will be trying to revolt against them. But finally we will come to a point where we will understand that Papa was always right.
Yes.
And,
yes.
and we are blessed in a way that they are also still trying to help us out. But as we rightly showed, there are many pitfalls in the second generation, and there are many third generation practitioners, and their problems are also quite high.
Yes.
So each has its own plus and minus, but winning the staff is, again, as Nilesh was asking, leadership is being by example. I think they have said those things very well, like being the first person to come and the last person to leave. That is something that worked, and being, I think, most of us will be millennials, is what I believe. So we millennials are thinking slightly different. Because of the smartphone era, we think we can do certain works slightly virtually also, whereas the generation like the baby boomers and the other people, right? So they believed in that physicality of work. So that is why we will have the same generational gap with our
Exactly.
children also. So this is a cycle, but each decade we'll have to innovate strategies.
Yes.
And finally, not filling in the boots,
Yes.
but you are the individual. And I like the last photograph. First 2-3 photographs, there was some kind of, the professional differences, but the last was like a colleague.
Yes.
That
Yes.
really summed up the
Yes.
thing. Yeah, thank you.
Thank you so much.
I would like to add something. I have a struggle between these two people a lot. So initially, the same thing used to happen. So what I changed in my, I have increased the chair time of the patient. So any retina patient, I have realized that every patient doesn't know me. Every patient knows him, and patient has come for him. And somehow the reception people has managed to give them my appointment. What I have been doing right now is that I have increased the chair time. By the time if I see any retina patient, I counsel him everything like इंजेक्शन लगेगा 3 महीने लगेगा ये लगेगा वो लगेगा आप सर से मिल लीजिए बट सर भी यही बताएंगे तो सो फाइनली व्हेन द पेशेंट गोज टू हिम ही सेज द सेम थिंग देन ही सेज कि जाइए वहीं मिलिए तो आके बोलते सर तो वही बोले हैं अगले बार आप ही का नंबर लगाएंगे सर 300 रुपये बच जाएगा मेरा तो दिस इज़ व्हाट
And another, I think we have been counseling our patient, even if we are doing just the workup, apart from cornea cases, if I see and work up his patients, I counsel them fully as if I am their doctor. So we are not just sub-secondary doctor and then the main बड़ा doctor आएगा जो medical colleges में होता है, वैसा system नहीं है. हमने देखा है, yes.
But to make that rapport,
Yes.
it is very important.
So if
For
they
me-
are convinced with you, definitely they come back.
For me, a benefit is my bulk. So most of the patient, if they see me, they think that this is Dr. Kanhaiya Singh, and they like see me and go off. So वो भी होता है जो पहले से नहीं मिले हुए हैं. But thank you for that wonderful talk. It was really heartening to see that talk. Thank you everyone for joining the UC session. We will just have a photograph and we will disperse to the oration that is starting.